Good morning. My name is Anita Day. My pronouns are she, her, and I am Chair of Eastern North Herts NHS Trust. Today is Wednesday the 15th of January, and this is a meeting of our Trust Board in public. I'd like to welcome members of the board, invited guests, and those of us who may be joining us via YouTube, either live or on catch-up. We have a full agenda today, so with no further ado, let me get started. In terms of declarations of interest, does anyone have any specifically to do with this morning's agenda? No, thank you. Obviously, our normal declarations are available on our website. In terms of apologies for absence, I've received an apology from Nina Janda, one of our non-execs, and we also have apologies from a couple of observers, Professor Zoe Aslanpour from the University of Hertfordshire Medical School, and also from Ivana Charma and Neil Tester from Healthwatch Hertfordshire. On the other side, however, very pleased to welcome to our meeting today Kirit Modi and Ros Aird from the Lister Area Kidney Patient Association, and also Patricia Fowler and as a patient who will be joining us for our patient story, but you'll be hearing more from them later. In terms of minutes, I should say, but first of all, in a slight change to the advertised schedule, because we have an important paper today that's had some public interest regarding our renal services, I've actually made a slight change to the running order for this morning. So we will be having, we'll be moving things around a bit, but we will cover all the topics. So, if we could first of all turn to our minutes of our previous meeting from the 6th of November, I wonder if I could have the board's confirmation that they are a true record of that meeting. Thank you very much. There's also the action log. We have a couple of items on there. Stuart, I wonder if you could take us through them, please. Thank you.
Yes, so just to confirm that both the actions are on track and are not due for this meeting.
Brilliant. Thank you very much. And I should have said, by the way, the first time we all speak, if we could introduce ourselves for the benefit of the audience at home. Lovely. Thank you very much. Our next section would have been questions from the public. And I believe, Stuart, we haven't had any this month. Is that right?
That's correct. No questions.
Thank you. So then let's turn to this important area of our renal services. There has been a lot of interest publicly, and also this is a really important topic for us as an organisation that wants to learn from what has happened here. We therefore have both a presentation regarding our patient safety incident investigation, which summarises what the full report says. And we also have a patient story from a lady who was directly affected by the interruption to the service at Bedford and about her experience. But let's first of all turn to Justin Daniels, our medical director, to take us through the presentation. Thank you, Justin.
Thank you so much, Anita. I'd like to start by saying that we've had renal services at Eastern North Herts for 36 years. I've been meeting with various members of the team over the last week or so, and one of the things that they've been very keen to tell me is that we've never before had an interruption in the service that we've offered, so this was a real shock to them when it happened. I want to acknowledge that this incident has caused harm. I want to acknowledge it's caused inconvenience both to our patients and our staff, and I want to say sorry for that. And I think that that's very important that I put that at the start of what I'm going to say. We supply renal services to 1.2 million people, and we have an incredibly dedicated staff group in the renal services team. They have worked so hard over the last year in order to make sure that the services for our patients are safe. And many of them have worked in the trust for very many years. I met with somebody yesterday who'd worked with us for 35 years, which is incredibly impressive. I also want to talk a little bit before I go into the presentation about the difference between a serious incident investigation, which is what we would have done a few years ago, and a patient safety incident investigation. With an SI, we would have done something called a root cause analysis. That probably would have found two causes of this. We would have said that's why this happened, and then we would have tried to correct those. The whole idea around PSIIs is that we will look for as many causes as possible so that we can learn as much as possible, and also so that we can spread that learning across the NHS. And that's why this is such a complicated document and has been so difficult to look at, and also has been so difficult to produce. The other comment before I start the presentation is that this is very much a Swiss cheese incident. What do I mean by that? I mean that this is an incident where a whole series of things have lined up, they've come together, and because they've lined up, and only because they've lined up, that has meant that we have ended up with the incident that we've had. Do you want me to pause for a second, because I think Patricia's coming in?
That would be helpful, thank you. Just a brief stop whilst Patricia, who's our patient that's very kindly agreed to join us today, is just entering the room. Thank you very much, and welcome, Patricia. Don't worry, you don't have to start immediately. We're in the middle of another of the bit proceeding, talking about the investigation, but we'll come to you shortly. But we're really grateful that you could join us today. Justin, back to you.
Sure, I'm Justin Daniels, I'm the Medical Director of the Trust, and I'm just talking about the renal incident, and I'm going to go on to try and explain what happened. So, in February of 2024, 69 of the 97 patients who were receiving dialysis at the Bedford Renal Unit had a drop in their haemoglobin. This led to concerns about the quality of the water at the unit, and we think that the incident has definitely contributed to 11 patients requiring admission to hospital, and 4 patients possibly requiring admission because they became unwell due to their anemia. In total, 30 patients required a blood transfusion as a result of this incident, and we know that 1 patient unfortunately suffered a stroke, and that is likely to have been caused because of this incident. So the Trust Patient Safety Incident Review Panel commissioned a patient safety incident investigation at PSII, and that was conducted by a learning response team. The panel incorporated some independent engineering reports that were obtained following the incident, and they also spoke with the patients affected, and they spoke to the Listic Area Kidney Patients Association, LACPA, and it's great that members of LACPA are here with us today. We put in place some immediate improvements as soon as we realised that there were problems at Bedford, and we then discussed the report at the Trust Quality and Safety Committee. The investigation made several further recommendations for the near, the mid and the long-term future, and I'm going to talk about those as we go through. So as I said, if we'd done this as a root cause analysis, we might have found 1 or 2 causes of this problem, but because we did this looking in the way that we did, we actually found 17 areas that contributed to this happening. And what I've done within the pack is I've grouped those into 11 main themes, and I'm going to try and go through those, and I'll take questions on that when I've done. So the first one was water quality testing. We were using a protocol for our water quality testing that we now know was outdated. We also know that the escalation process contained within that protocol was not correct. And I'll talk more about water in a second because it's really important. An average patient having dialysis is exposed to between 300 and 600 litres of water each time, and that water comes from the tap water, and that water contains chemicals which are deliberately put into the water to make it safe for drinking, but those chemicals are not safe if used in dialysis fluid. So the job of the water treatment plant is to remove those chemicals before they get to the patient. There were also problems with the tools and the equipment in the Bedford Renal Unit. There was an alarm panel that had been installed when the unit was opened 12 years earlier, and that panel had never worked. There were a number of other failings, technical failings within the unit. There were also some problems around communication. We didn't have a clear process around escalation of abnormal results in water testing, and again, that was tied up with a protocol. We had some problems with governance. We were looking very carefully at the water quality as it went into the plant, but we didn't have an appropriate engineering response to looking at the water as it came out of the plant. We also weren't following all of the manufacturer's guidance. Now, the manufacturer's guidance has changed over time as renal units have evolved. When we first opened renal units, they were very much things that doctors with an interest working with engineers had produced. That's become far more professional over time, and there has become quite strict manufacturer's guidance, and we were not up to date with all of that. We also have an incredibly dedicated technical team within the renal department, many of whom have worked with us for many, many years. They were managed by somebody who didn't completely understand what they were doing. They were managed by somebody non-technical, and that seems to have been a problem within all of this. The technical team were responsible for keeping the show on the road. We'll talk about capacity in a second, but we were running the unit at 100% capacity. That meant that there was very little time for maintenance. So all maintenance had to be done overnight or on a Sunday. There were no fallow shifts when maintenance could be done in the unit. And that sometimes encouraged the use of what seems to have been short-term fixes in order to keep the show on the road. The technical team were very proud that they'd never had to pause a dialysis session. And finally, with the governance, there was a very unclear contract with the commercial providers of the unit. The contract was out of date. The contract was complex to read, and it wasn't entirely clear who had responsibility for which bit of the maintenance. That led in turn to very unclear lines of responsibility regarding the preventative maintenance. There also were some gaps in the technical oversight and some understanding around that. We know that as part of those short-term fixes to keep the machines running, there is a possibility that some of the softener components, some of the filters, were not installed correctly. And we know that there was a pump that was used, that one of the engineering reports has been described as being installed in such a way that it might have led to pressure spikes within the system. Again, that's really unclear whether that did happen or not, but the engineering report has raised the possibility of it. We also, as an organisation, have been on a journey with our risk management. Risk management is very important in a large organisation. There were a number of risks on the risk register relating to the capacity to dialyse enough patients and also the age of the plant we were using. But those risks were poorly assigned. For example, they would be assigned to a member of staff who might move on into a different job rather than the role of the person who should be sorting the problem out. And we know that those risks were not responded to in a timely way. There were also issues around capacity modelling. There were different understandings across the organisation of what capacity our renal services were running at. There was a different understanding in different departments, but we know that there is a massive demand for renal dialysis, and we know that that's growing by roughly 3 or 4% a year across the population that we serve. We currently dialyse about 600 people, and we know that that demand will go up year on year on year, yet we were running our services at almost 100% capacity. We know that there are some problems with our staffing model. Our technical team has 5.5 whole-time equivalents, and in the last 10 years, we've increased the amount of dialysis we've done by 30%, including a big increase in our home dialysis, but we haven't increased that team. We also know that we were using a large number of bank and agency nurses, and that we needed more nurses as part of our team. And finally, we were using temporary fixes to all of our physical environment at Bedford in order to keep it running, and we know that some of those are part of the reason why this happened. So, having gone through the things that had gone wrong, the learning response team identified 28 areas of improvement that were required. And there are a number of those that needed to be done immediately, and everything that needed to be done immediately has been done immediately. But there remain some longer term improvements. So the improvements we've completed so far include large parts of the Bedford water treatment plant being replaced. There are still some areas that need to be done, but the large parts of that have been replaced. We've replaced all of the water treatment unit at our St Albans plant. We've introduced clear governance around the responsibility for the changes to plant engineering, with authorised engineers playing a very significant role in that. We've also introduced very clear governance around the responsibility for the water quality, both going into the treatment plant and coming out of it. And we've made really significant changes to our risk management structure across the trust. We've got a number of future plans. So we will introduce an additional 20-station modular unit on the Lister site in March of this year. We will then go on to refurbish the whole of our Lister renal dialysis unit. We have recruited additional nurses, and we're making really good progress with that. We're also working with our commercial provider to ensure that the contract we have is fit for purpose and up to date, and that contract should be signed very shortly. And we're doing really significant work around demand and capacity with our commissioners. And that's a problematic area because we're paid for this work on a block contract. So the more work we do, the more difficult it is for us as an organisation because the amount of money we get paid doesn't change. But we're working with our commissioners to try and reach a way forward on that. So I want to say some thank yous. I want to thank the investigation team, particularly Dr. John Bramall. I want to thank Claire Carr. I want to thank Sam Hoskins and Kim Walker. I also want to thank LACPA for all the work that you have done with us, for supporting our patients, for supporting our staff teams, for being part of the investigation, for being such an incredibly important part of the work that we do as an organisation. I want to thank our patients because they've had to move to different units. Some of them have needed to be admitted to hospital. They have had a really difficult time over the last year. And I spoke to a number of patients last week, and they have been incredibly supportive of our staff as well. And lastly, I want to thank our staff. They have gone above and beyond to keep our dialysis systems working over the last year. They have worked at night. They have worked at units that they were not used to working to. They have worked unbelievably hard to support our patients, and I'm incredibly grateful. And I'll stop at that point if that's okay.
Thank you, Justin. And I very much want to echo that last bit about our thanks. I mean, this was a very difficult time, and actually it was everybody pulling together that meant that we managed this as well as we could. And again, also want to applaud the thoroughness of the investigation which John Bramall and the team did. I think there was a lot of transparency and openness, which I think is absolutely to be applauded in this situation. Right, I'd like to open it up first to any members of the board that will have any comments or questions, and then I'm going to turn to Kirit Modi from LACPA to make a statement. But first of all, any questions or comments for Justin? David.
My name's David. I'm a retired clinician and I've worked in the NHS all my life. And first I just want to reflect. I think it's fair to say when I first qualified as a doctor, when harm occurred, we didn't even identify it as harm. It was just one of those things. And I chair the Quality and Safety Committee here at the Trust, and I just want to reflect that the investigation has been really very assuring to me, very thorough, very considered. Like all investigations, has its ups and downs, and it has to get there. It's hard work and it's difficult, but I think it's really useful. And the honesty that we now show in the NHS is really fantastic. So it's just some simple questions really. So there are a number of themes here, but just popped up over the years. So contracts, for example, are clinicians involved in clinical contracts? Capacity, the NHS has a history of overusing facilities or not having enough facilities, depending on how you look at it. So things are very fragile inherently, and then the slightest thing it falls over. So there's more themes which Justin has identified, but I just want to know, is the trust and how is the trust asking itself, well, we've had an issue with a contract here. Are all our other contracts okay? We've had an issue with capacity. Do we have other capacity issues like in E&A? So it's a very general question about, are we doing that and how are we doing it?
Thank you. Maybe I'll take the capacity question first and I'll take the contract second. Martin, I don't know if you want to talk about contracts as well. As a trust, we receive £15 million a year of capital allowance. We use that money to keep all 4 of our hospitals running. We use it to buy medical equipment. We use it, so we have some really difficult choices to make on how we spend that money. And I think over time that has been incredibly hard for us as an organisation with all the competing issues that we have to deal with. We have a significant backlog of engineering that we need to do to keep our infrastructure working. I don't think we necessarily have spent enough on capacity for renal services in the past, and that's something that we are now addressing. So there will be a new 20-station unit on the Lister site, which will give us very significantly increased capacity. It will allow us to deal with new patients coming forward needing dialysis. It will also give us the time and space to allow us to properly maintain the equipment that we have. So the first thing that we'll do with that 20-bedded unit is use it to decant our patients from the Lister site so that we can then fully refurbish our renal facilities on the Lister site. So we will have the right capacity going forward and we will get those numbers right, albeit there are still some really difficult negotiations to do with our commissioners in order to ensure that the trust receives the money it needs in order to run those facilities. Do you want to talk about contracting or what?
I think in terms... Hi there, I'm Martin Armstrong. I'm the Trust's CFO and Deputy kind of CEO. I think in terms of contract, we have hundreds of contractual agreements as an organisation, and multiply that out across our local system and nationally, and it's an industry in terms of kind of contract management, and those contracts will range from contracts that we have that span multi-million pounds agreements, for example, to our domestic services, to things that are kind of much smaller. In terms of the management of those contracts, I guess there's 2 aspects that we might look at. One is the tendering of those contracts, when you originally award them or indeed intend to renew them, or indeed what the management of those contracts looks like on an in-year basis. How do we regulate the commercial relationship between the trust and the supplier? I think ideally that is a combination of both a technical exercise and a professional team. We have a procurement team to kind of support that, but it also needs management and clinicians involved in that as well, because obviously in some cases, renal dialysis is a really good example, the technical regulation of that contract is not something that a procurement specialist would feel confident to do. It needs clinical and operational support kind of in there. I think we recognise as a trust, and we're going through a process at the moment in terms of identifying some of the key business skills that all of our staff need in order to perform the duties that they do in a management capacity. And I think procurement, tendering, contract management is one area that we know we need to invest in the capability and competencies of our team to be able to discharge that. I think that's a challenge in this trust. My observation would be it's a wider challenge across the NHS as well, but it's definitely an area that Justin's identified within the investigation kind of report that we need to work on and need to improve.
Thank you. Richard.
Thanks, Anita. My name is Richard Oostrom. I'm a non-executive and the chair of Finance and Performance and Planning Committee. I've got 3 questions after repeating the compliments. I think this is a really thorough and good and open investigation, which I really appreciate. One is, who makes the decision to pause or close the service? The second one is, what controls are we building in to prevent this from happening in the future? I can see a lot of actions, but you see, the team wanted to do the right thing. There's a lot of a way of working that was kind of gradually applied, and we run a risk of falling back into the same again. So what controls? And the third one is, and I think that's also maybe what David implied. So there's a number of themes here that do not only apply to renal services, they apply to many other services. And what are we doing to take the lessons learned out of this and try to apply them elsewhere?
So let me try and answer those, and if colleagues want to come in, then please do so. Who makes the decision to close the unit? It's made by the staff who are there on the day. It's made by the nurses in consultation with the consultants that run the unit and the technical team jointly. And unfortunately, we have had a subsequent event where there was concern about safety at the unit. No harm came to patients. There wasn't a problem, but the team made a decision effectively to pull the line, to say that they should stop because there was a concern about the hardness of the water. It's absolutely right that the clinical team there on the day, in conjunction with the engineering team, have the right to do that. If they are concerned in any way, shape or form about patient safety, then they absolutely have the right to do that. I guess what we're giving them with the expansion of the number of renal stations we have is a much easier solution to that problem, because what we're saying is if we can't use one of our satellite dialysis units, we will have capacity to provide for those patients elsewhere. And for me, that's the most important part, because I don't want them thinking that they can't stop the line, because how will they then go on to dialyse the patients? So that's sort of answer to point one. In terms of the controls, that's about having the right governance in the unit. Do we have protocols that say when this happens, this is what we do? And we know that we didn't have strong enough controls in the unit at the time this happened. And that's something that the PSII team have gone into in very great detail, and we need to get that governance exactly right so that we know that when things are changing within the unit, we're responding in the right way. But we also have the right engineering controls so that when our technical team are making changes, those are changes that are then checked by our authorised engineers and that they are happy with those changes. So we've brought in some very significant changes to how we do that and some much tighter control of how our engineering work is done. Again, going back to the report, I think one of the major issues was that much of the work was being done in the middle of the night in order to keep the show on the road. And we don't want to push our teams to have to work in that way. We want to give them some cushion so that they know that they've got time to do the right thing. And the lessons learnt. So we've already started to talk about this report within the organisation. Following today, we will do more of that within the organisation. But also some of our renal team members have started to talk about this outside the organisation. And what I hope is that that will continue to happen. And I hope actually that we will put some stuff into some of the scientific journals around renal. So there was a similar episode to this at another hospital in London about 20 years ago. And there was some really significant learning nationally from that. And we need to make sure that the same things happen as a result of this. And that's why the degree of clarity within the report is so very important.
Jill.
Morning, my name is Jill Hooper. I'm a newly appointed clinical and non-executive director here and a member of the Quality and Safety Committee. I just wanted to make a couple of comments, if I could, observations. Firstly, to thank Justin very much for such a very clear summary presentation there of very complex issues, so it's much appreciated. I would like also to echo the comments that you made, Chair, of the openness and transparency and thoughtfulness with which the investigation's been done, and also say that from the Quality and Safety Committee, having given some consideration to this issue last week, it was very clear the pace and the focus that had been given to address all the issues, which was very impressive. And the final point, just to say, whilst acknowledging all of the good work of the staff, particularly within the renal unit, what struck me from the discussions at the Quality and Safety Committee was how wide across the organisation cooperation had been forthcoming from teams in every corner of the organisation, estates, operations and others, to contribute to this, which was extremely impressive.
Thank you for your comments, Jill. Any other questions from any members of the board on this? Questions or comments? Oh, Adam.
Adam Saul-Jones, the Chief Exec. I just want to pick up that thread of that wider implications beyond renal. And I think if there is one issue, because not many of our departments run water treatment plants and the very technical aspect, but I think there's a theme that we've looked at over the last year on areas where we've had some concerns about or things have happened, and it's the principle of how much we devolve and how much we keep centralised. And there is, I think, a human desire to manage everything. If you're a local team, I want to control, I want to manage. And yet we know in certain areas, whether it's digital, whether it's engineering, whether it's people, there are central expert teams. And I think probably over the years what's happened, that devolution has gone to a level where people are very happily managing locally. And I think this is an example where we lost some of that proper engineering expertise because the local experts didn't really have the full range. So I think when we talk about that theme, and we've looked at a number of other areas across the organisation, particularly those smaller departments that can be easily buried within bigger ones, that we've actually really worked very hard to shine a light. And building on this theme of transparency, we've actively spent the last year trying to find problems, and we will continue to do so, because it's only if you look, find, you can address. And I think that's definitely a point of learning, that we've seen a bit of consistency. So as we restructured our operations and our new divisions and looking down, we're really trying to make sure we've got the dotted line and the solid lines on the chart in the right places. So there is a feeling that we can have more and more local ownership and, as been said, the clinicians, the operational leads driving change close to the front line, but making sure we've got that strength through the corporate infrastructure, so that if we take digital as a kind of allied thing, that all the best practice around cyber security and other things that might not be in the head of the local IT manager looking after a department's IT. So I think for me, there's one of the themes that we've spread more widely.
Yeah, no, I completely agree. And I would add another thing that I think we need to be cautious of across our organisation. And interestingly, it almost picks up from what Jill's last comment. I think there was also a bit of a thread here about local heroic leadership, about people wanting to keep the service going, trying to look after their patients, doing everything they could to keep the train on the tracks. But actually there comes a point where actually you need to say, you know what, we need to hold the line. So I think things like putting in that modular unit that will give us the capacity to do that. But I think it's both testimony to our staff that they want to actually keep things going and they want to look after our staff, our patients, I should say. But we also need to make them feel confident to say, you know what, I have some concerns about doing this, and feel able and empowered to tell us if they are concerned. So I think there is a cultural piece there that I think we need to bring out too. And I see that along with what Adam was saying, those are the kind of things that we need to put those lenses across everything we do, because I think that those are potentially bigger issues that we need to be aware of across many areas. But no, I think as I say, thank you for your comment. I'm going to turn now to Kirit Modi, Chair of the Lister Association Kidney Patients Association. We always call you LACPA, and it's much easier to say, to ask for your comments on the investigation. Thank you.
Good morning, and I want to begin by thanking Anita Day for this opportunity to participate today in the discussion about the report on the closure of the Bedford unit last year. Having read the report carefully, I think the question we need to consider is, have we learned and applied the lessons from the Bedford closure? In addition, I have some serious concerns about the current provision for kidney patients and believe that dialysis patients are not receiving a satisfactory service, both because of the fallout from the closure of the Bedford unit last year and other issues related to future capacity, which I'll share with you shortly. At the outset, I want to emphasize that in raising concerns, this in no way reflects on Dr. Andrew Findlay, the Clinical Director for Renal Services, and his team, and I want to thank them for the incredible efforts in managing the fallout and providing dialysis at other locations during these closures. I'm a kidney transplant recipient, and my first visit to the Lister as a patient was over 30 years ago. I've had excellent care from the renal department, and I'm most grateful to many staff for their care and support over many years. The closure of the Bedford unit last year was followed by a second unplanned closure of the same unit and the unplanned closure of the Lister unit. In addition, there was a planned closure of the St. Albans unit, and a planned closure of the Lister unit will take place in a few months' time. These 5 closures have increased our concerns about the infrastructure and the resilience of the service into the future. The closures have had significantly affected the lives of over 300 patients in the 3 units, that's Bedford, Lister, and St. Albans, and their families. And many patients are anxious, and there has been an erosion of confidence in the service. Patients and staff were severely impacted, with some traveling to Northampton and Milton Keynes for dialysis, and some were having to dialyze at early hours of the morning. Dialysis is an invasive, relentless, and exhausting treatment, lasting around 4 hours, 3 times a week, and life expectancy is reduced by it. The Trust provides dialysis to around 625 patients at 5 locations, and these patients are amongst the most vulnerable of those looked after by the Trust. LACWA welcomes the immediate actions taken as a result of the investigation and the report Justin has very kindly shared with us and with the board. However, we're disappointed that the capital project to relocate the home dialysis unit, scheduled for this financial year, has lost its funding. This is the second time funding earmarked for this project has been used elsewhere. We have discussed our concerns about this with Martin Armstrong when he kindly attended the LACPA committee meeting, and request that the funding of around £1 million be reinstated in the 2025-26 financial year. The pressure on capacity for dialysis at all 5 units have been known for some time, and the projections provided by Dr. Pravin Jivaratnam show an increase of over 5% per year of dialysis patients over the next few years. And this is right across the 5 units. While I accept what Justin says about the 20-place modular unit at the Lister, we have similar pressures at the other 4 units as well. There's an urgent need to engage with NHS England and the integrated care boards to develop detailed plans now. There's a significant risk that unless we give this priority, we will end up with a situation with overcrowded units and minimal resilience in the provision. And again, we've raised this matter with Martin Armstrong. One aspect not touched in the report is addressing any impact on the mental health and well-being of patients because of the closures. We have initiated discussions with Jeanette Akonubuni, renal manager responsible for this area, and LACPA has offered to provide half the funding for any proposals that arise out of this development, so long as the Trust funds the other half. Again, we raised this matter with Martin Armstrong. I'm concerned that despite welcoming the section in the report on lessons learned, this depends on the priority the management team gives to the implementation of the future plans, as well as the urgent investigation of the second closure of the Bedford unit and the closure of the Lister unit. LACPA has consistently recommended that the investigation should be undertaken by someone independent of the Trust. Again, we've raised this matter with Dr. Justin Daniels. In conclusion, LACPA greatly values the relationships it has developed over many years with staff in the renal department as well as the Trust. Our purpose is to improve the lives of kidney patients, and we continue to work in partnership to restore patients' confidence in the renal services provided by the Trust. But we cannot do this without commitment from the board on 4 areas. Firstly, fully address the issues raised in the report. Secondly, develop robust funded proposals to ensure that the dialysis capacity reflects future demand. Thirdly, reinstate the funding for home therapies project, as this will alleviate some of the pressures on in-center dialysis units. And finally, set up an independent investigation of the unplanned closures of the Bedford and Lister units. Thank you.
Thank you. That's incredibly helpful, and I'm very, very grateful for the support that LACPA has given to the organisation. Let me pick up the investigation bit first. So we have done the PSII into what happened in February of 2024. We're now taking the two other closures through our governance process, and we will make a decision through PSERF, which is the Trust's body that works out how to do investigations, how best to investigate both of those other closures. As I spoke about in answering some of the questions before, the first closure took place because staff rightly were concerned. On that occasion, no harm came to patients. There was nothing wrong with any of the equipment. There was nothing wrong with any of the infrastructure. On the second occasion, there was a failure of a piece of infrastructure on the Lister site, and that failure of infrastructure meant that we couldn't use the site in the way that we normally do. But again, no patient came to harm, and there was no disruption to dialysis. So we will absolutely take those through PSERF, and we will form a view as to how we best investigate those. I'm really excited by the proposal from LACPA to think about how we provide psychological support and increase psychological support to our patients. We do have psychology already within our renal services, but I absolutely recognise the need to support patients through what is an incredibly difficult period of their lives, and we have to get that right as an organisation. We've written this report, and we've taken a long time over writing it, and I know there has been some criticism of how long that's taken. But we've written it because we wanted to get it right, we wanted to do it thoroughly, we wanted to go into the dusty corners of the organisation and look to see what was happening. Having written that report, there would have been no point doing that if we as an organisation didn't make changes, if we didn't learn from that, but also if we didn't spread that learning much wider than our organisation. And those are all things that I absolutely commit to do. I think it's incredibly important that we continue this very strong relationship that we have with LACPA as we move forward, and I'm really grateful for all of your input. Thank you.
Thank you, Justin. If I could turn to Martin, please.
Hi there, Kerrit. Yeah, I think in terms of the question around capital investment into the infrastructure for renal dialysis, I think when we kind of met just before kind of Christmas, I sort of talked the group through some of the investments that we have made this year in response to the incident itself, and that's money and resources that we've committed in terms of water plant refresh at St Albans and coming up at Lister, as well as Bedford as well, and then the modular unit itself, and that's about £3.2 million worth of capital expenditure kind of in this year. I think, as Justin mentioned a little bit earlier in response to David's kind of question, some of that has come through, the amount of capital resource that we have is finite as an organisation, and we've had to make some difficult decisions around reprioritising spend from other areas and moving it into future kind of periods. At the moment, that means it's difficult for us to kind of commit to the Renal Dialysis Training Centre being in the 25-26 kind of programme, but I have given the commitment that as a trust we'll continue to look at how we can bring that investment forward, because I do understand the investment that we're able to make in home dialysis capacity has an impact in terms of the number of stations that we will use on there. So that does remain a priority for the trust on there, but I think there's also a recognition that in addressing one series of problems, there are other risks risks and priorities that the Trust also has to manage across its other portfolio of services, and that remains significantly challenging. We have an infrastructure within the Trust whereby we review that as a management team. Generally, it's not my personal decision around how we deploy this resource. It is a management kind of function on there. I think I would also kind of say, in terms of your recommendation for us to continue to work really closely with commissioning colleagues, both in specialist commissioning and the ICB, yes, and we will continue to do that. I think there's been very powerful modelling that both the renal and our business teams have worked through in terms of looking at the demand for renal services sort of going forward relative to the level that is currently resourced at by kind of commissioners. There's a significant gap in there, and we want to, and we will be having very urgent conversations with our commissioners around how that gap can be kind of be breached on this. So there's a firm commitment to work strongly sort of on that.
Thank you very much. I don't know, Adam, if you or would you like? Shall we hear from Patricia, our patient?
let's-
Patricia, you've been waiting very patiently there, and I'm really grateful for that. I don't know. Has Patricia got a microphone that she can use? Got one? Great. Great. Thank you, Patricia. You were a patient, or are a patient at Bedford Renal Dialysis Unit, and were affected by the closure. So really would like to hear about your experience of how it felt for you. Thank you.
Good morning, Board, and thank you for this opportunity for me to give you feedback on a difficult time, and my experience probably isn't typical of what some of the patients went through. But my experience was that you have a tremendous team out there that pulled together on both occasions and worked well. And I was just amazed. When I came back into the unit after the second closure, I said to Lydia, is there someone I can write to congratulate them on how well the staff did? Not just the management, you've got to include the driver who drives from Leicester to Bedford. You've got to include the people who clean the unit. They all pulled together as a team. I felt that it was amazing how this could happen, but I could still have my treatment 3 times a week, 4 hours of treatment, 12 hours a week. I was amazed that, yes, I had to go to Leicester. Yes, part of the time I was in Leicester due to a problem with my fistula, but I had renal at the home department where the home dialysis go. I had treatment at 11 o'clock at night. I remember even having a ham sandwich at midnight, like a midnight snack, and a cup of tea, which was wonderful. And on no occasion did I hear any of the staff, whether they were renal staff at Leicester or renal staff at Bedford, complain. I had to change the hours. It was inconvenience for them. Only person that I heard complain was one of the patients once in the waiting room. You said he couldn't drive to Chiltern. And I feel that all the other units pulled together to help us achieve that goal. And it's a tremendous job on the behalf of the staff. And you must be immensely proud of these people pulling together. I didn't feel that I had a bad experience. I thought it was amazing. I can't praise you enough. In fact, if I could have given gifts to each unit and each department in Leicester, I would have done so. But it was slightly out of my budget range. I just feel that you have it's hard to put into words how I feel about the staff and the management. We all know that times are difficult for all of us, but I've been a renal patient now for just over a decade. It's the people that have been brought into my life, like Alison and Lydia, have known me for just over 10 years when I first went to Leicester as a renal patient. Unfortunately, I'm a below-the-knee amputee. My life was saved. That was a shock for my family. Yes, I've lost my eyesight, but I'm still here. I'm still the same person that I was. And you've also allowed me, by looking after me, the care I've had. It's difficult to put into words because it's brought the three most important people into my life, my grandchildren. And 10 years ago, I didn't know I had a future like that. I just don't know how to commend you and the staff and management in the trust that pulled together. It wasn't a hard experience. It's a bit, I suppose you could class it like a swan on Bedford River, elegant and regal, just swimming along. But underneath, the little legs are going like this. So obviously it impacted hard on the management team, but at Leicester and at Bedford Renal Unit and the other units that helped. But you've just got to be so proud of them, and you must let them know that what they achieved over the two periods in February and March, they did wonderful. And if the care continues as it is and the resources are put into place to help support that, renal patients are going to be grateful. I don't know what else to say, apart from you did a tremendous job.
Patricia, thank you so much. Really, really appreciate you taking the time to come down here today and tell us. And it's lovely to hear that you had.
It's a pleasure. It was a pleasure.
That's great. And thank you to Lydia for bringing Patricia in or supporting Patricia today. David, I'll come to you in a moment. I just wondered, Teresa, I meant to come to you and I apologise. I don't know if you have anything to add to what Patricia said.
Press the button. I'm normally quite loud, apologies. Chair, I think Patricia said it so beautifully. Thank you, Patricia, on behalf of everybody in the renal teams. Lydia and Alison and I and many, many others have spent long hours trying to work out some of the logistics and actually just to echo what Patricia said about in that time of great need, what we saw was great courage. Staff working night duty, long days, weekends, and really in the essence and the spirit of doing the right thing for the patient. So with your energy and your story, I absolutely feel that we can make a difference for the future, Patricia. So please stick with us and keep giving us feedback, good and bad. But a massive shout out, particularly to the nurses at Bedford Renal Unit, at Leicester Renal, and also Chiltern as well, and St Albans. Thank you, Chair.
Thank you, Teresa. David, you wanted to comment?
Very briefly, well, thank you very much for those incredibly generous words. I'm just reflecting the report tends to concentrate on harm for obvious reasons, and yet we must recognise there's an incredible amount of inconvenience. You know, a lot of people had to change their arrangements, both patients and staff. And yet I thought what the words we just heard show how caring individuals can make a difference to patients. So thank you.
Well said, David. Right, I think since I can't see any other hands, I'm going to wrap this one up, but I'm going to leave the final word to Adam.
Thank you, Anita. Just want to make 2 or 3 points. I guess at different levels on this. So I think the first thing I want to do is echo Justin's comments at the beginning, because the reality is, as a result of this incident, we know a number of patients were subject to an unnecessary, potentially, procedure, and we know that one patient particularly, we believe a strong likelihood came to harm as a result of it. So that is the central tenet of this, and I would add my apologies to Justin's, to that individual and their family particularly. But as David has just said, we recognise inconvenience has been caused. And it was fantastic to hear from Patricia, and I know that echoes a lot of what Justin heard from patients when he's been over at Bedford in terms of the way things were wrapped round to minimise that inconvenience, recognising it's there. I think Renal is a unique service pretty much in our organisation, in that very few of our patients have a long-term relationship with us, because in an acute setting they come in, we fix them, as it were, and then send them on their way. There's a genuine relationship with renal patients, and I think that's one of the features why the LACPA work is an exemplar in our patient engagement work, because there are people that want to invest, and Curate is an example of that. People have been through services and want to give back by the effort. And so I would add, I'd add my thanks to the ongoing work of LACPA, but also it is important with this group that ongoing input and shaping of the service happens. I think we will see future disruption, because even in Curate's statement, a number of the closures were planned, and we will in future, when we have to refurbish and replace equipment, plan closures in order to move it. And as the largest provider of renal services across the region, and such a disparate service, we would do that with any of our services. A ward refurbishment, but you might be relocated to the ward next door. We move people from Bedford to Chiltern to Lister, etc. So I think the lessons of how well the response happened are ones we need to take forward. A comment on the PSERF itself. I think just re-emphasising, this was very early in this new model. It's not our framework, it's a national framework with the intention of really looking for learning rather than blame. And as Justin said, it's a far broader process that highlights things that might not even contribute to the issue, but actually if there's learning there. And we took the decision to bring this to the public board. It's not something that's mandated by that process, but we felt it's really important in our desire to be very transparent, because sadly things do go wrong, but we want to be very clear that we're giving confidence to our population, and that we as a board feel properly assured, and if not, we challenge harder and push back. So we will continue that commitment to transparency. And finally, I think it's a really important point, because this is an incident that happened, and actually it's happened a while ago now because of the process to go through, and services have been up and running, and we've heard some of the investment. The challenges of Renal have been understood in terms of the capacity, and Curate's call quite rightly to say we really need to get the resourcing right. We need to get, as he described, a funded service, something that Martin particularly has been working on for an extended period of time. We had hoped going into next year, and without going through the whole of the NHS finance, most of the NHS is funded on this block arrangement where you're given a set amount and you just have to cope with it. Lots of our work, particularly our planned activity, we are paid for the activity we do. And so therefore, if more people need hip replacements, we get paid more money. We had hoped Renal was going to move into this new space next year, and that would allow us then, based on our growing capacity, to be able to fund that. We've been told now that actually that is not going to happen, and we will remain on a block. So the negotiations have to happen. But I think as an organisation, with some of the consequences we've heard today, we have tried to provide when patients need to try and provide, and that's stretched our service. Other units maybe take a more clear view that this is what the capacity we have and this is what we're going to do, and we shut the door. We don't want to get to that position, but it is really important that we continue the work. And as Curate says, it's with NHS England, this is specialist commissioners' work rather than our local ICB, to really get the funding at the right level for the population we serve, because otherwise this will remain a challenge. And as Martin said quite clearly, this is one part of our service we need to balance with a challenged financial environment going forward, both in terms of the investment in infrastructure, but also the ongoing costs.
Thank you, Adam. I'd like to bring this item of the renal services to an end now, and I'm just going to take a quick pause because I think Patricia and Kirit and Ros may want to be leaving the room. So thank you, Patricia, again. Thank you so much for attending. We're really grateful. Thank you also to Kirit and Ros. Really great to have your support, and I know working together we will do the best we possibly can for patients in our area. Thank you very much. Just a quick pause then whilst we just rearrange the room a little bit. Thank you. Right, welcome back. Thank you for that brief interlude. So let's carry on with the rest of our business, and we'll pick up some pace. The next item on our agenda is my report as chair. I've got three things I just want to draw to the board's attention, and I'll try and do it as quickly as possible. The first one is, as the board is aware, just before Christmas, we successfully concluded some discussions with Unison regarding the agreement of the backdated payments for some care support workers who were rebanded from Band 2 to a Band 3. Given the timing of it and the fact that we needed to get on with it, I took the decision to take a chair's action to confirm that agreement. However, this is our first meeting since that agreement, so I'd like to ask for the board's ratification of that decision. The board was fully briefed through that period, but of course it was all done informally. So can I ask for the board's confirmation of that ratification? Yes. Thank you very much. The second item is a very sad one. As some members of the board will be aware, last Friday morning there was a very, very distressing incident on the Lister site where a local lady fell from the multi-storey car park. And despite the best efforts of emergency services, she was unable to be saved. Her death is not being regarded as suspicious currently, and there are ongoing investigations going about the incident, both here and also with Hertfordshire Partnership Foundation Trust, which is the NHS trust that provides mental health services in this area. Our thoughts are absolutely with the family of this poor lady, but also I'd like to express our gratitude to our patients and staff on that morning who were undoubtedly were very seriously inconvenienced and disrupted their journeys both to and from the trust at a time when several of the roads around the centre of the site had to be closed off. So we're grateful for your forbearance. And my final comment on this is if for any staff that were affected by the incident, really would encourage you to reach out to your managers if you need any kind of wellbeing support, which is available to you. My third point is a slightly brighter one, at least. For those of you that know that we've been in the process of applying for teaching hospital status. Now, we have a paper coming very shortly that will talk about where we are in that with more detail, but I am delighted to say that another step has been taken on that road, and we will very shortly be welcoming Professor Zoe Aslanpour as a NED on this board, and also that Justin Daniels, our Chief Medical Officer, will become a board member at the University of Hertfordshire Medical School as the next steps to that on that journey. So again, some really good news for our patients and also our staff. I'll stop there and I'll hand over to Adam.
Thank you very much, Chair. The paper here, my usual report, just highlighting a few bits, and I won't go through in detail, but I just want to emphasise one or 2 points. We are clearly still in a busy winter period, and the period between Christmas and in this first part of January has been particularly pressured on our emergency services, but services across the country, and it's widespread being reported in the media around some of the challenges. The region declared a level 3 incident, which has been operating, stood down yesterday afternoon, where region take a kind of coordinating role because of the pressure across the whole of East of England. Interestingly, in terms of our ED performance, whilst it was pressured, it held up reasonably well during this period. But where we unfortunately saw probably the most pressure and impact was for those patients requiring admission, and particularly those who had flu, which has been one of the major drivers of the pressure over the last 2 or 3 weeks, and patients therefore needing a side room, and with our estate not having maybe as many side rooms as some hospitals, those patients often were kept in ED a lot longer than we would want because they were able to be isolated in ED, whereas they weren't in the ward setting. So we apologise for those patients that were under the care of our services but not in that ideal environment. And as a knock-on of having patients in ED, the ability to offload ambulances quickly was a challenge. We had periods where offloads were happening immediately, but other times it was quite an extended delay. Again, a feature we've seen across the country, and we were certainly not at the worst end of that, but no less for every patient that waited longer in an ambulance than we would want. We do apologise. The second bit of our activity largely is the planned care, and people will be aware that the government launched with NHS England a couple of weeks ago now the elective recovery plan for this parliamentary period. We are waiting for the detail, and I will come back to the board when we have more of that, which we hope to get soon. But there's some big ambitions in there, including more access using digital, the NHS app to feature increasingly people being able to book and cancel appointments, direct access to certain tests without needing to go through other services. So we need to see the detail and how that works out. We need to make sure our digital systems, both now and that we're implementing over the next 18 months, support that. But one of the concerns for us is that the government have worked out, and NHS England have modelled, to get compliance with their waiting times target over this Parliament, there is a kind of staged improvement process. Now, we know that we've put real effort in since the pandemic to reduce our waiting list, and we're up amongst the best in the country in terms of eradicating long waits. But as a result of that, when the government look in the macro level, it could be that they don't require us to do more than we're currently doing, and it's possible they might actually require us to do less than we're currently doing, because others will need to equal up. So we need to work out what that looks like, but it has clearly big strategic implications for us. So we will continue to reduce our waiting lists and the time people wait, but the pace and the scale of which we do that in part will be determined by what we're commissioned to do. And similarly with the renal service, we provide a service, but there is someone who is commissioning that from us, and we'll have to see how that plays out. In Thriving People, I've just a bit of reflection really of the last year and how many national awards we've won or been shortlisted for, really reflecting the breadth of the services we provide and the excellence that is being recognised. And it's really pleasing to say that since the last board meeting we received the Armed Forces Covenant Employer Recognition Scheme Gold Award. That's quite a mouthful, but really a reflection on how we look after the armed forces, current personnel, veterans, families, etc. I'm really proud to once again receive that Gold Award. In terms of seamless services, and we focus both internally and externally in this area, the big drive in our system is to try and reduce the amount of frail older patients that end up being admitted to a hospital when we know that that's not really the place they need to be. But because of other services not being aligned or alternative options, that becomes the default. And there's an ambition to reduce those admissions by 25%. A frailty conference was held in November across our East and North Herts place with all the providers, lots of clinicians, really working through what those models can look like going forward. That remains a big ambition going into next year. And another really exciting project that's run by the Trust, which is a postnatal contraception service that has been really driven by some of our clinical leaders in women's and children's services, and really trying to get to a position where women can receive contraception advice and treatment without having to be bounced through various parts of the system, but while they're in, after delivering, if that's what they want to do, being able to try and provide a bit of a one-stop shop. So real credit to the team that have driven that through. And then mention here of Professor Nikhil Vasudev, one of our urologists who has been a big advocate for the use of robotics and a big part of our robotics programme. Certainly not the only part of it. Lots of our clinicians really drive that work. But people will remember he became a professor at the University of Hertfordshire last year, and he's been recognised in New York for some of the really innovative work around robotics and AI particularly, and what that's looking like. So another example where we're kind of really leading the way nationally and internationally in that space. And then the very final comment I just want to point here is to make the board aware that Tom, our Chief People Officer, has been successful in securing the same role at the Royal Free Hospitals Group in London. Tom will be leaving us at the end of this financial year, and we are just about to start the process to seek a replacement for Tom. But as sad as we are to see him go, we congratulate him on that new role, and more will be said in the March meeting when he leaves. Thank you.
Thank you, Adam. Any questions or comments for Adam on his report? No? Thank you very much. Moving on then, Justin, Establishment Order.
So this is a really nice bit. You'll remember that in May last year we talked about seeking teaching trust status as a trust, and we're now at a point where we have agreement from the Secretary of State, and we want to change our name. This reflects the massive amount of teaching that takes place within the organisation. We teach undergraduates, we teach postgraduates, and we do that across multiple professions, and we're acclaimed as an organisation for doing that really well. I want to give credit to Jennifer, who is sitting over there, who has done all of the hard legwork over sorting out all of the paperwork for this. And really, I want to ask the board whether you're happy with the idea of us changing our name.
Thank you, Justin. Can I have the board's approval to us becoming East and North Hearts Teaching Hospitals NHS Trust?
No, teaching.
Teaching
NHS
Trust. Sorry.
We do a lot more than just hospitals.
East and North Hearts Teaching NHS Trust. Thank you. Yes. Are we happy with that new name?
And for anybody who wants to know, we won't need to change the paperwork immediately.
Exactly.
So just to be clear on the final bit of the process, so this is being proposed, the name change, at our suggestion. If we approve it now, it just goes back in the final stages again for...
So it needs to be signed by the Secretary of State, but they have undertaken to do that, providing we agree as a board.
And we are proposing that would take place from the 1st of April
We are.
As our preference date.
Exactly. And at that point, then we'll be able to welcome Professor Aslanpour to our board as a new non-exec at that date too. Thank you, board, for your agreement. Then, thank you. Let's move on then to the next item, which is the Integrated Performance Report, which, as in our normal way, is in 4 sections. But I'll turn to Martin. Do you start or do we start off? I can't remember. How do we do this? Is it Teresa goes first? You don't do any kind of intro, do you? So, would you like to do an intro, Martin? Really. No, okay, fine. Right. Well, then, in which case, we'll start with quality and Teresa. Thank you.
It's the quality microphone, thank you, Chair. So I'll be brief on the quality section, hand over to Justin. So we have seen a slight increase in C. difficile numbers, but it's really important to see that we're under a trajectory for year to date, so that's a really important indicator. What we're not seeing is any cross-contamination of patients, and we're not seeing any poor outcomes, so it's quite important to say that. Really pleased that here we are with no MRSAs, which is phenomenal. And earlier on we touched on some of the challenges around flu, so I think it's quite important to say whilst we're not seeing flu numbers in this IPR, we will see some in our next one. So COVID numbers are plateaued for us, nothing to be alarmed about, but certainly flu and influenza A has been a big challenge for us over the past couple of months. We've cohorted patients and maintained safety at all times. If I could just touch on friends and family tests, we had our PACE meeting, in fact only yesterday, very good attendance, 4 members of the public there, and it was really good to see the compliments coming through, matching some of the areas that we touched on earlier in the board, but particularly the voice of the patient at PACE was very powerful. And then just a couple of brief areas you'll see in the chart and in the narrative that VT has come down, and myself and Justin and others, in fact Dr. Bramwell's here as well, will be working on how we make sure we bring that up. So we are seeing, if you look at the 24-hour period of time, and if you look on the charts and electronic boards in our wards areas, you'll see that within 24 hours the VT is completed. And last for me, Purpose T, which is a way of mapping out pressure ulcer prevention, has been adopted, and we're just rolling that out. And I'll probably stop, take questions, and hand over to Justin for mortality.
Thanks, Teresa. If it's okay, Anita, I'm actually going to leave the mortality stuff to the Learning from Deaths report, which I'm going to do later on in the meeting. So I'm going to skip over that from now. I guess the only additional comment I'd like to make on top of what Teresa said is how pleased I am to see the reporting of good care events. That's something that we've been actively pushing in the organisation. Everybody knows that we report when things go wrong, and we use Enhance as a system for doing that. But if you look at the chart, we're also gradually seeing increases in good care reports, and we need to learn from those in exactly the same way as we learn when stuff goes wrong. But I'll pass over at that stage.
That's great. Any comments on that? If not, I'll come to David as Chair of Quality and Safety. David, anything you'd like to add?
All the important things have been mentioned. And the next is really just if I could have an update. So there was some questions around staff sickness, vaccination rates, COVID, flu rates, and I just wondered where we were on that.
So the sickness that we've seen, and I'm slightly treading on Tom's toes, but has mostly been short-term sickness over this period of time. We haven't seen particularly high rates of longer-term sickness. We've seen staff being off with respiratory illnesses, as you would very much expect. The vaccine story this year is not a great story for any NHS trust across the country. We haven't seen great uptakes of the vaccine, and I do think we need to learn lessons about how we deal with that next year. We're not an outlier in terms of how many of our staff have had the vaccine, but nor are our vaccine uptake rates great. In terms of the flu itself this year, from an epidemiological perspective, it's actually been quite a complex year, because whereas we would normally see a predominant strain across the UK, we haven't seen that this year. We've seen a multiplicity of different strains, some of which have been vaccine sensitive, some of which haven't. But I think that's probably why the flu situation has been more complex this year than in previous years. I think the particular difficulty that, like other hospitals we've faced over this period of time, has been the coming together. So around Christmas, we were seeing a peak in COVID levels. We were lucky as an organisation not to be hit by norovirus, but there is also a new strain of norovirus out there. And those trusts that have been particularly hard hit by that, because it's been a particularly easily spread strain. We saw flu A peaking just after the COVID peak, and we'd had a background of RSV levels all the way through. There is a new RSV vaccine, as you're aware, being offered to older populations and pregnant women, but that was only introduced in September, so we weren't expecting it to make a significant difference over this winter period. So I'm sorry I've given you a really complicated answer to quite a simple question, but I think the whole area is complicated. For me, the lesson for next year is, what do we do differently to try and persuade our staff to be vaccinated both against flu and COVID when that's offered?
I remember as a young GP treating a young man who died of flu, and that's only once in a career, but it was such a tragedy, and we perhaps sometimes forget how flu can be so deadly.
Absolutely.
Thank you for that. A question, Richard.
Thanks, Anita. Teresa, you mentioned C. diff and MRSA, but I noticed a spike in E. coli as well. Can you maybe comment on that?
Yes, I can. So we record all E. coli. We screen for E. coli for community patients that attend into our hospital, and including inpatients. So we know that there are some particular hotspots. Patients with long-term indwelling catheters, they may well have been an inpatient and then go back to the community and come back to us. They are a high-risk group for us. But also patients with any vascular access. So lots of training and support to make sure that patients haven't got any cross-contamination. What we're not seeing is any food contaminations that are causing that, but nonetheless we've not seen any bacteremias, and we've not seen any mortality impacting. But the big thing here is education and prevention, particularly around any indwelling catheters or devices.
Thank you. I noticed the increase again in the number of emergency readmissions within 30 days, now 859 on this report. And I wondered if we might, obviously this is a complex area and there are no specific targets that we have here, but I wondered if this might be an area that we ask the relevant assurance committees to look at, to ensure that there is the assurance that the relevant analysis and actions are being taken to reduce that optimally.
I'm really happy to try and bring a paper on that to Quality and Safety. Just to reassure the board, whilst we've seen an increase in the absolute number, we have not seen a significant increase in the percentage, and I think it reflects a higher number of patients being admitted to the organisation over the most recent period, and therefore a higher number of readmissions. We do benchmark our readmissions, and in fact I was going to talk about it in the mortality paper, but for me as medical director, what's important is to look at readmission rate, to look at length of stay rate, and to look at mortality rate altogether and then triangulate those three things. So whilst I'm not overly concerned about the increase in absolute numbers of readmissions, I'm really happy to take that to quality and safety, if that would be helpful.
That would be enormously helpful, because I appreciate everything you've said there about the importance of triangulation and the complexity of it. And so that's the very reason why I suggested, I think, as a new member of the board, I'd find it very helpful that that level of triangulation is being undertaken somewhere, so that we may all be assured that that is an appropriate level or not.
Yeah, absolutely. That sounds like a sensible thing. Any other comments? Diana.
My name's Diana Skeet. I'm a non-executive director here at the Trust. My question is just in relation to the increases in the V&A incidents reporting. I'm just wondering whether we're going to link that to the training I know that we've got available at the Trust, because I think we do have training around de-escalation, I believe, and I'm just wondering whether that's linked at all, if there's going to be any, if that's going to be incorporated in addressing the issues.
Thank you, Dana. Teresa Murphy, Chief Nurse here at the hospital. Yes, we have seen an increase, but quite a localised increase around Children's Department, but also in ED, and some of it's been linked to patients and families having to wait. So there's no doubt about it. But that training, which is excellent, I have to say, we've done a big piece of work with our heads of nursing, trying to get as many staff as possible through that de-escalation training. What we'd like to also do is do some joint work, I believe, with our security teams. I know that Kevin might mention that, but sort of trying to make sure, particularly out of hours, for those teams that are together covering ED and those touch points like paediatric ED, to make sure that they're working as a unit to try and de-escalate and make sure that we don't end up with some of the reported instances we've had, Dan. Thank you.
Thank you. Kevin.
Kevin Howell, Director of Estates and Facilities. I'd just like to say a lot of the increase is probably better reporting and support that's being given. So we routinely run a violence and aggression group that reviews all of the reports that are sent in on violence and aggression, not only on paediatrics but across the Trust. That's a large group of people who come from various fields, and the clinical teams and nursing teams have started to go out and actually report to people and get people to actually verbalise what is actually happening, so we're taking it forward. So whilst it is reported better and we're dealing with it better, I think there's the support for the teams is better as well, and that they realise it. So there has been a surge. I think it's the links then with the nursing teams, the security teams, and the clinical teams feeding back. I think we will see a reduction in this, because I think people are realising that the zero tolerance for this trust does exist, and that's also our partners as well. So it might well be that the reporting has got better rather than the violence and aggression has got worse.
Thank you for that. And I have to say, I've actually booked on to the de-escalation training myself next month, because it isn't just, it's focused on clinical staff, but anyone that could come across somebody in distress that might need to manage a situation. So, I will let you know my views shortly, but would encourage anyone who thinks that they might be in that situation to book on, as I have done. Thank you very much, all of you, for your contributions. Let's move on then to operations, and I'll hand over to Lucy.
Thank you very much, Chair. I'm Lucy Davies, Chief Operating Officer for the Trust. To run us quickly through the operational performance for November for most standards and for October in relation to cancer. As Adam's already alluded to, in urgent and emergency care, our performance on the 4-hour standard in particular has remained a challenge, and in November it was particularly impacted both by staff short-term sickness that we've just been mentioning, and also a number of closed medical beds due to more than one business continuity incident that were impacting at that time. It did deteriorate further in December, but I'm really pleased to say that at the moment, January month to date, we're performing at 69.3%, which is a really good performance for a January period of time, and reflects some of the early work from our new interim Director for Unplanned Care, Claire Gowland, and the influence that she is bringing to process, particularly at the front door for the moment. On cancer waiting times, we continue to achieve all three of the key targets, and they both on a year-to-date basis and in that month. And although there are sometimes some seasonal dips in performance in the 62-day performance, it is compliant year-to-date, and we do exceed national performance on all three of those standards and pushing to improve further with some focused areas of attention. On referral to treatment times, and I'll comment in a moment on community paediatrics separately, but excluding community paediatrics, which is reported separately to the bulk of our acute referral to treatment performance, we are continuing to show improving trends in month. And although we have struggled with treating all of the 65-week patients at the end of each month, that tends to be, I mean, those are in numbers of, it was 25 at the end of November and a number beginning in the 30s at the end of December. Though the reasons for those tend to be about half and half patient choice or complexity versus the capacity challenges that we have, most particularly in trauma orthopedics. But underlying that, there is good progress being made in virtually all other specialties to 52-week by the end of March. And in total RTT terms, because the government have announced that we're going to start to move back towards a performance on the RTT, measuring on that proportion of patients treated within 18 weeks. Our performance in November was just over 59%, which is very much in the middle of national performance, which is 58% nationally, and we will continue to work hard on that. Indeed, started some planning conversations in the last week within the organisation. Community paediatrics remains a challenge for us, with a paper coming to our trust management group later this week to go through in more detail progress that's been made recently. There is we are a full part of system planning to bring services together for neurodiversity assessment for children and young people, which sits behind the increase in waiting times because of the proportion of follow-up to new in our service model. We continue to struggle to be able to see new patients within a timely way, because of the number of follow-ups that we're seeing, and also because of the increase in referrals for assessment for neurodiversity that nationally has been seen, certainly kind of starting during COVID and continuing since. We have started to see the early signs of a plateau in referrals to those services in the last few months, so we're hopeful that that gives us a slightly more stable basis on which to plan. But and there are system resources going into a single front door, which is the first stage of the kind of more integrated service across Hertfordshire, and in support for families while children are waiting for their first assessment. On diagnostics, we're sorry.
That sounds really interesting, and it'd be great to see, once it's been to the Trust Management Group, what that system-wide approach looks like. And obviously for something of this nature, that's really what's needed. I guess my question was, does that include dealing with some of the very long waits, kind of in terms of backlog, or is it about kind of new referrals coming in? What's the plan around? Because some of these families, that represents a very large chunk of a child's life, doesn't it?
Yeah, absolutely. The system plan aims to deal with both, and of course you'd serve the whole population better when you sort things out from the beginning of the pathway, but commissioners haven't invested this year in the level of support that they did for backlog last year, so that the funding remains a challenge for that. To move on to diagnostics, we know we have very particular challenges in audiology and also in our MRI service. and I'll comment on them in a minute. But when we exclude audiology from our diagnostic numbers, that both the number and proportion of patients waiting over 6 and 13 weeks is declining in a really positive way, with about 38% reduction in our waiters over 6 weeks between April and November, and steady reduction every single month in those other modalities. That we are working hard on a business case for investment in MRI services, which are due to come to relevant committees in the next month or so. And on audiology, there's progress now being made with active meetings with other providers in the system about mutual aid and support from subject matter experts, and the completion of the validation of both the paediatric and our adult PTLs, and progress being made on plans for sorting out the estate so that we're in a better position as new staff come on board. And we welcomed a new paediatric audiology lead to the trust in the last week or so. So as all of our improvement actions in relation to paediatric audiology come together, we have a more stable basis on which to plan our recovery from the service pause that remains in place for most of our paediatric pathways.
Thank you, Lucy. Richard, Chair of Finance, Performance and Planning, do you have any comments that you want to add on in terms of the operations part?
No, I think Lucy's highlighted all the important points.
Okay, any further questions? Jill?
I'm very grateful to the additional information on the community paediatrics, as that proactively addressed a number of the obvious questions from the data in front of us, so thank you for that. It was just a very general question around the overall RTT percentage performance of 59%, and whether there was enough certainty yet to give an indication of the trajectory of that in coming months?
Not yet, because it's going to require a lot of demand and capacity modelling. And we started the discussion about different approaches to that by specialty and within the resource that we have. But that will be able to be shared at FPPC as the work progresses.
Okay. Thank you. I don't see any other hands, so let's move on to finance. Martin.
Thanks, Chair. As colleagues will kind of remember, we set a financial plan for this year to deliver £1 million kind of surplus. That included some fairly ambitious targets within that, key components in order to achieve that, most notably the delivery of a £33 million CIP programme, and also some pretty kind of challenging targets in terms of elective performance and kind of delivery. At the month 8 kind of reporting point, which is covered within this kind of pack, we're reporting year-to-date surplus of £200,000, and that's a little way short of where we intended to be in the year by about £700,000. In terms of our official reporting, we're talking about that gap being largely driven by industrial action earlier on in the year. I think in truth, below those headline messages, the organisation's financial performance is much more complex at this stage. We have seen a significant number of financial pressures arise, and we're managing them through the year. Particularly, mobilisation of additional elective capacity has happened somewhat slower than we had anticipated, and that has created some financial slippage against the plan. That's also been kind of added to by, again, some mobilisation delay in terms of kind of savings programmes across our key divisional and operational kind of areas. And that, again, has been further supplemented by some expenditure pressures we can see across a range of budgets, particularly kind of maternity, renal, medical staffing more kind of generally, and also some significant pay and non-pay pressures, particularly within kind of pathology and the use of medical consumable and equipment costs in there. We've been able to manage those on a in-year basis by the deployment of a range of non-recurrent kind of reserves, and that has been clearly helpful in terms of the organisation's financial performance, but clearly doesn't represent a long-term or a sustainable means of managing kind of financial kind of delivery. I think the focus that we've had as a management team and discussion at the Finance Committee is around trying to ensure that we're leaving the current financial year with exit run rates that are much closer to financial balance than performance has been in the year to date. And divisions have constructed a range of financial recovery action plans in order to take the steps to achieve that. And we continue to monitor that, and we've set up a financial recovery board that meets on a monthly basis to try and steer and husband that activity. The delivery of kind of our financial plan through to the remainder of the year will be challenging for the trust. It'll certainly be challenging at a system level. It's challenging at a regional and a national level. However, we remain committed as an organisation to get as close as we can to the delivery of that original kind of surplus plan that we committed to. Planning guidance for next year remains kind of outstanding at the moment. However, some of the headline messages that we've been informally briefed around in terms of resource allocation means that 25-26 looks incredibly challenging. But I think we'll cover some of the mood music and the consequences and the impact of that in the private piece of the board. So I'll stop there.
Thank you, Martin. Richard, as chair of FPPC, do you have any additional comments?
No, I think Martin has really highlighted the most important points. I'd like to repeat that although we've seen some positive increase in activity in October, November, December was a lot less, and so is January, so that's still a risk. I think the other thing is I think financially we manage really well, using the balance sheet in some cases. But the concern is really about the exit run rates, which is not so much this year's concern, but the next year's concern. So really important to note. Final point, our forecast includes also an assumption around funding of the EPR program of £1 million, and that's still uncertain too. So maybe, I don't know, Martin, if you've got anything else to say about it, but I just want to make sure that we realise that.
Yeah, thanks, Richard. I mean, that was always a high-risk item that we included within our plan, with a clear understanding with NHS England and the ICB of the risk that was attached to that, and the uncertainty that remains in terms of that funding. I think both through myself and Mark, we've continued to place pressure into NHSE in respect of the identification of kind of funding, but I think that it feels unlikely at this stage, but we'll continue to kind of press the point, and certainly we've emphasised that as a key risk issue in terms of the delivery of our target.
Thank you. Karen, I think you wanted to come in.
I'm Karen McConnell. I'm a non-executive director at the Trust. It's just a comment and a question. So obviously the pressure on us going into 25-26 in terms of finances has already been noted, and I think the size of the savings programme is likely to be quite high, and that's something that we are all aware of. So one of the areas I was just wanted to ask a little bit about was in relation to one EPR, which is of course a very important programme for us and links in well to the need to improve our digitisation across the Trust as well. Is there any scope for additional funding of that to help us through into 25-26, given that it's such an important programme? Really linking it back to the fact that we hope to get £1 million in it for this year. So really, is there anything that we're likely to get through to next year, given that as yet we haven't received that £1 million? Thank you.
I think that remains a really difficult question to answer. As you know, we've funded about £4 million worth of revenue cost in this year's kind of budget, and that's been a pressure to the Trust's sort of bottom line. Our financial planning going forward had identified a similar requirement for the 25-26 sort of financial year. We have received a modest amount of capital kind of support for the programme, but I think in terms of the identification of revenue revenue kind of funding, I think that probably remains sort of unlikely, and it remains also a challenging issue for the NHS in terms of the categorisation of digital spend. And I know we, as a board, we've talked about some of the discussions that we've had with our auditors around the correct treatments within our books that I feel we are following, but that is very different to the way that the NHS currently funds EPR kind of programmes. I don't know if there's anything you'd want to add, Mark.
No, so as you say, I mean, we received a nominal amount of revenue from NHSC, which was 140k for this financial year, and we've received about £750,000 of capital, but it doesn't appear that there's any more revenue support for us, only capital potentially.
Thank you for that and for the various questions and comments. I don't see any other hands, so let's move on to the final section of our IPR. Tom, on people.
Thank you. Hi, I'm Thomas Pounds. I'm the Chief People Officer. So just a few points to highlight from the report. Firstly, around our vacancy rate, we set a target at the start of the year of 8%, and I think we believe that to be quite ambitious considering the change in strategy around internationally educated staff that we haven't recruited this year. Certainly nowhere near the proportions of previous years, but we're really pleased to say that for a couple of months where it sort of flatlined a little bit, we've had some really real improvements with newly qualified members of staff coming on board and starting in December and more coming in January. So we're at 8.8% vacancy. And we've seen the relative impact on temporary staffing as well, where we've seen positive reductions, particularly around our agency usage, which was down to 2.3% of our pay bill in month. The caveat there is around the sickness, and I think it was raised by David earlier, that we certainly are seeing spikes in sickness from staff, particularly going into December, where we've seen the level of flu circulating. We have been promoting and pushing, obviously, our vaccine campaign to get as many people vaccinated as possible. It is lower than it has been in previous years, even though we're at sort of 30% of the flu vaccine uptake. But that is, I must say, is very much reflective of a national picture where we're seeing a lower response from people. So we do have to really reflect on the learning from this year's campaign and think about how we focus on next year. The other area around kind of our absence, obviously we've been looking at kind of stress levels, which is one of the areas that have been kind of a concern for us. I'm really pleased to say that we've have a more formalised partnership arrangement in place with Essex Partnership Trust now as a mental health services that provide psychological support, and that support will be available to staff, and it's really vital for things like when incidents happens they can provide that psychological debriefing type services. So we're looking forward to developing that partnership. And then finally, just to say that we concluded the field work of our staff survey. I'm really pleased to say that over half of our colleagues responded to that staff survey. That's never been achieved before since the staff survey began in this organisation. It's certainly not our ultimate aspiration. We obviously want to be much higher than that, but it really shows a positive trajectory in terms of people wanting to engage, give us their feedback and have an influence on the way that we do things. And I do believe that as we have increasingly focused on the importance of staff or employee voice, that will continue year on year, and I'm really hopeful for that.
Thank you, Tom. Janet, as Chair of People and Culture Committee, do you have any further comments?
Thank you, Chair. Just really to say it's great that we've got that survey result, because we'll hopefully get the data from that relatively soon, and that will really tell us where are the areas that we want to focus on. And just also well done around the kind of vacancy rate and the reduction in contingent staffing, because I know that's not easy, particularly in the kind of current situation. So obviously it's not entirely your responsibility to it. So well done more generally, I think.
Thank you very much. I think in the interest of time, I'm going to take a slightly early short break for us to grab a cup of coffee and do whatever we might need to do. If I could ask us please to come back at, is 25 past going to be too mean? Is 5 minutes? Can we do it in 5 minutes? Okay, start back at 11:25. Thank you very much. Welcome back after that short break, and I'd like to get on to the next item, which is our Learning from Death report, and I'll hand over to Justin.
Thank you so much. I'm just going to take the board through this, and I'll happily take any questions at the end. So if we start on page 88, you'll see that there are 4 risks that the Trust considers are important when thinking about learning for deaths. Those risks are unchanged over time, and we've made some really significant progress on our SJR numbers, and I know that that's something that people were worried about last time, and I'd explained that we'd moved to a new app in order to collect those. All 3 of our mortality metrics remain better than would be expected for a trust with a similar patient population. Our length of stay and our readmission rates also remain within the expected regions. In the next iteration of this report, we're also going to add in the large cumulative baskets for the reasons why patients die, because I think that will allow us to understand with a little bit better context when we see an outlier, because the pattern that we've seen over time is that when we see an outlier group, that group sits within another much larger group, and the overall group is in a reasonable position. So an example would be urinary tract infections. We've seen more urinary tract infections than we would expect as a cause of death, but we've actually seen significantly less overall sepsis infection as a cause of death, and UTI is a subset of that larger group. So what I'll do with this report next time I bring it is actually put those larger pots into it so that I can contextualise it and hopefully make the report more helpful. We do continue to have a very small number of preventable deaths. The analysis around prevention is a subjective analysis, but we think that currently of all the deaths that occur across the Trust, it's about 3%. And that's obviously a figure that we need to watch with very great care. And I'll stop at that point and take questions.
Thank you, Justin. Any questions for Justin on the learning? Richard.
Thanks a lot, Justin. Two questions, really. There seem to be a lot of, let's say, joint coding clinical activities ongoing. Is that highlighting an underlying data quality issue? How are you addressing it? And the second one, you talked about the preventable death percentage, which, of course, is really important to keep a close eye on. Do you have any comparison to peers for that at all?
2 really good questions, thank you. In terms of the coding, we actually have very good quality coding at the Trust, and I have a great deal of confidence in the coding. However, whenever we get a 3 standard deviation outlier in, the first thing we always do is go and look at that coding. And the coding rules that are used are interesting and somewhat archaic. So you'll see, for example, that there is an outlier with cystic fibrosis in there. When you go into that data, there are no deaths in the Trust from cystic fibrosis, but there is another lung condition which isn't separately characterised but is lumped in with cystic fibrosis, and that therefore leads to a concern about that particular disease area. And that's quite common because of the hierarchy which is used by the coders. I'm probably going into a little bit too much detail with that. So we will always go back and look at coding when we get a challenge, because that's the first place to go and to understand why the deaths have been coded. But actually, I think the quality of coding is good overall. Your second question about preventable deaths, actually, I think that's a really good idea, and it's something that I will take away from today, and perhaps, if that's okay, bring you an answer for the next board.
Thank you very much. Any further questions for Justin on learning from deaths? Nope. Thank you very much. Let's move on then to the next item, which is Board Assurance Framework. And Stuart.
Thank you. I'm Stuart Dalton, the Head of Corporate Governance. So before turning to the 2 executive leads for the 2 spotlighted BAF risks, I would say to the board that there's nothing significant to flag regarding the non-spotlighted risks in the context that the board, the last board, saw a significant refresh of the BAF where we added assurance areas and also timescales for actions added. A further point I just want to emphasise is we're trying to get better traction on actions. So one of the things that I will be doing via the committees, if now that we've got timescale columns, is flagging to the committees if there are any overdue actions, given this relates to delivering our strategic objectives. Conscious of time, I will then turn over to Tom for the first spotlight. Sorry, it's Martin for the first spotlight of risk.
Okay, I think, clearly within the context of the kind of BAF, there's a number of kind of issues that we'd want to flag in respect of your system and kind of financial kind of constraints. I think there's probably a little bit of kind of the current position of where we're at, and then there's also probably the reality of where we're going to find ourselves kind of in kind of coming months. In respect of current system financial constraints, we've talked earlier on in terms of our financial performance, but the financial performance of the system has been extremely challenged during the course of this kind of financial year, and current estimates are that we will struggle to achieve our break-even position despite the deployment of considerable non-recurrent sort of resource, both internally from the ICB during the course of the year, but also kind of externally from support directly from NHSE. Of course, that will mean, that has meant already, that organisations across the system have taken a range of kind of extraordinary steps in terms of financial recovery and financial constraints. We know that we've taken some of those steps ourselves, and the Finance Committee has looked previously in terms of your external reviews that have been done by PwC in terms of our own measures and system measures as well. However, I think moving into next year, on top of an existing underlying deficit that we have, I think the emerging picture around the financial position for 25-26 means that underlying deficit is likely to be even more challenging as we move into the new financial year, and the scope and scale of efficiencies and productivity and improvement that will be required in order to balance that will be probably of an order of magnitude that the system hasn't experienced in some considerable kind of time on there. I think obviously that creates a number of kind of challenges for us as an organisation. I think that means that we will need to step back and reevaluate our approach to efficiency, productivity, improvement kind of delivery, and what a variety of different strands can contribute towards that picture. I think that there is a contribution that some of the development of the production system and kind of standard work and waste reduction can make into that environment. We have a PMO function that is very focused on helping us understand our productivity and efficiency kind of opportunity, and then we have an emerging picture with divisions as they develop capability and competency within their own teams in order to be able to match some of these challenges. Will that be enough in order to unlock the scale of the paradigm shift in financial performance that's going to be required? I think that's something that we are increasingly wrestling with as a product of our business planning for next year. In terms of kind of further expectations, I think that challenging environment is only going to be added to by, I think as Adam's kind of referenced a little bit earlier on, sort of today, the elective reform plan. I think envisages elective delivery, or the financial flows that underpin elective delivery, as being kind of very different, and rather than being that safety valve maybe that organisations have been able to use to do more work and more work at a margin, that pot is likely to be kind of capped kind of this year, and I think that will again reframe our focus back into how can we deliver extra work using the resources that we already have, perhaps more intensively than we currently sort of do, less reliance on premium cost activity around WLIs and kind of locum, sort of further dimension of challenge sort of for us. So I think when we look at the BAF, sort of at the moment it has a nice helpful kind of 12 sort of rating, and I think that probably reflects the here and now in terms of what our kind of financial performance and delivery looks like as a tactical exercise in 24-25. But I do think that in the coming months, even before we get to 25, sort of 26, as we see the planning picture emerge more fully, as we understand the constraints that we're going to be operating kind of within, as we kind of craft our response to that, I would expect that rating would increase quite significantly.
Thank you. Tom. Oh, sorry.
Tom, go first.
Oh, no, yours a question, yours a comment.
Yeah,
sorry.
if I could, and I think Martin's point is exactly right, that I expect as the planning guidance becomes clearer, this BAF risk will go up. And I think just for a bit of context, if you consider that when you look at the financial performance of the organisations within our system, we are at the top end. We know as an ICB, we are in the minority of ICBs now that haven't been taken into a special measures regime, implying that the ICB is at the better end of where many systems are. And we know, going up even to government, the constraints in here around investing in the NHS already, but other government departments will be challenged. So there is constraints all the way through. It's already a matter of kind of public record that the likely position next year, once pay awards, national insurance, etc., funded, that we're likely to get a real terms decrease. And as Martin has said, we've got the cap on the bit that is able to kind of trade our way through. And I think it's just a really salient point, bearing in mind what we've considered already today. We know that under Renal, there is a constraint there, because if we could have opened and run more stations, we would have. We've heard about community paediatrics, which again requires investment, or there is a constraint. And we could bring another 20 services into the conversation where we'd like to do more, reduce waiting times, improve capacity. And I think it's the world we are really crashing into, that this idea of constraints in terms of where do we choose to invest of our resource, where does the ICB choose to invest in terms of the various providers, and some that are particularly challenged, where right the way through to government policy and where they invest. So I think this is going to be a real risk underpinning what we do into next year.
Yeah, completely agree. Completely agree. Can I go straight? Oh, Karen, sorry.
So just one question really relating to capital, because we know our capital resources are quite limited, and we know we've had to divert some of our resources this year into Renal for all of the reasons we've discussed earlier. And we know that we have an extensive backlog maintenance that we need to address. So I'm just wondering whether we also need to look at the BAF risk and do something explicit in relation to capital. And I think there's a pressure also arising from a change in the procurement regime that we heard about at Audit Committee yesterday, which may impact our ability to spend money right at the end of the year.
Yeah. I think in response to that, I think that perversely that the picture around capital perhaps looks a little bit less bleak than it does from a revenue kind of perspective, and we can see from kind of the budget there's an expectation of additional funding going in, particularly around kind of backlog maintenance. We don't yet have the understanding how that will flow and how we'll access that, but I think that's a source for some degree of kind of optimism. We know that our share of system capital is broadly going to remain the same, so that's the 15 million-ish that Justin has kind of referenced earlier. I think in the course of the last 6 months, we've set up what we call a critical infrastructure group as a management kind of community that's led by Sarah James as our divisional kind of Q, and that brings together a wide constituency of colleagues from operations, from finance, from estates, etc., to try and make those rational, difficult judgments about how do you take £15 million and try and manage risk and also development in a sort of coherent way. And I'm really pleased to how that group has kind of developed on there, and I think will continue to be a significant kind of part for us. I think you're right, the new Procurement Act that will come in terms of February gives us another difficult dimension to, very often the way that the NHS doles out capital is sometimes a little bit piecemeal and comes kind of quickly at the end of the year when you don't expect it. The Procurement Act will give us some challenges around how we do that following proper procurement process, and then we talked about that at the Audit Committee kind of yesterday, so another dimension of challenge for us maybe.
Thank you. If we could turn to the other risk, please. Thank you, Tom.
Yeah, I think it's helpful when sort of describing this risk is just to give a little bit of background in terms of the journey that we've been on. So this is scored currently a risk level of 12, and it has been for the last 2 years, and that was having come down from a 16 from the year previous. So obviously shows over a period of time we've done a lot to kind of put good plans in place along with a clear people strategy, a national people plan, to make sure that we are focusing on the kind of the future of workforce models and the skills that are required, but particularly looking at the skill shortages and the vacancy rates and driving those down. So I think you can see demonstration of some improved controls. Now, I think, and I do believe that 12 is still correctly assessed from where we are at the moment, because what happened in those 2 years really is a lot of recruitment that was done, I would say, in a less sustainable way. And like I said in the earlier update, we've made a conscious decision not to continue the expansion of international recruitment based on the NHS long-term plan, which very much focuses on all of the training routes that we have available to us to fill those skill shortages gaps, whether that's through university and education placements or some of our internal apprenticeship type placements. Now, part of the risk I think going into next year is that there is quite significant numbers and commitments in that long-term plan around how we're going to complete that clinical expansion work with those internal development pipelines, but there's less clarity at the moment around the funding that would then enable and support that. So while we have a number of people and a growing number of people, so we had 30 internal nurse associates this year coming through into nursing roles, which is fantastic, and that is the sustainable model. If we really want to expand that, there's a balance around the upfront investment in those years around supporting the apprenticeship and allowing the supernumerary time against the sorts of the shorter term fix of kind of the international recruitment cohort. So we're still in this kind of difficult dynamic, I think, and I think we've done reasonably well this year, but I think it's something we're going to have to be really watching carefully next year. And I don't think that means our strategy changes. I think we've got the same kind of plans around kind of internal development pipelines in terms of the number that we've got, but it's again against a kind of a changing demand. So where we're seeing in some groups, we're seeing digital innovation starting to change what the workforce looks like in certain areas, but we're seeing that in other areas, clinical areas particularly, we're still having to expand to meet the demands, particularly where we're driving at reducing waiting lists, particularly looking at our medical workforce and how we really effectively plan for that, use our job planning systems, good demand capacity to make sure that we're able to recruit to those posts in a much more substantive way.
Thank you, Tom. Kevin.
Thank you, Chair. I'll just asking a question, I suppose I'll refer it back to me because I'm not specifically looking at these. What I don't see on the BAFs when we do this is we've done a lot of work, and Stuart's gone through a whole lot of work, and the teams have gone through a lot of work to review the risks. And in some of these, it may have been that we over-egged the risks previously and it dropped down, but I'm not sure on the track systems I could find it. I was trying this morning to see where it was. This was a reviewed risk, not through work that we'd done, or a balancing of risks between across the divisions and things like that. And I think that would be helpful. It's not saying that a lot of good work hasn't been done. I'm just saying that sometimes some of the BAF risks were over-egged for various reasons, or may have been exaggerated, if you see what I mean. So the scoring ratio was higher than we would have expected. We've done it in estates. We've had to go back through a number of areas where in historical times people put it down because they thought a higher rate would have been more capital being spent on it, whereas it needs to be balanced. And we've done that, and I'm just wondering, is it reflected in the BAF report there anywhere?
Yeah, absolutely. So in the cover sheet, I make the point there's only 5 of the BAFs which are actually red rated, which is actually a real compliment to the work of the committees to try and drive down our biggest strategic risks. Having said that, that's still 5 where we're saying actually we've got real concerns, and that's why each of the committees dedicates time to focus on that. So I'd say that's probably more of a corporate risk issue, which we are working on about realistic scores.
Thank you. Stuart, do you just want to wrap up this paper? Oh, sorry, Janet.
That's all right, thank you. Just a comment really on one of the pieces in this paper about the need for greater triangulation around the kind of finance and people agendas, and I definitely would echo that, and certainly we had a conversation at the People and Culture Committee about the rating and whether it was right, and I think I was looking at it without having the history and kind of challenging, particularly with Tom going to Pastures New, whether we had that right. But I think particularly in terms of the potential changes around how elective is funded, and certainly what I've observed is we kind of, you know, we look at increased activity and then want to match kind of increased workforce to that, and actually understanding what that workforce plan specifically for our trust looks like over the next kind of 12 to 18 months, I think feels like a very important piece of work if we're really going to manage this risk effectively.
Yep, completely agree. Jill.
Sorry, very quick comment, if I may. As a new person, I commend everyone for contributing to such a comprehensive and easily digestible document, actually, as a framework, incredibly effective. I understand that you've recently taken the decision to use a 7-level assurance score, and it is both an art and a science, is it not, to adopt something new like that? And I just wanted to make a comment, if I could, for executives to consider, take away and consider, and that is that level 5, of which there are a number of things within this report identified at 5, indicates something's amiss, indicates that the outcomes that you were originally seeking have not been achieved. So that would, for me, focus me towards areas of obvious discussion in the future. And I'm not sure in reading and understanding as a whole that maybe that's what was intended. So without going into any of those issues today, I would just invite executives to reconsider that aspect specifically, because it does focus our discussions in the future.
Yes, thank you. I think that's a really good point, because in some cases 4 is actually more assuring, because what you're saying
Absolutely.
is you haven't done it yet.
Absolutely.
And therefore you don't expect anything to have happened.
Yes.
But at 5 you've made a change and it hasn't
Yes,
delivered.
absolutely.
So no, I agree. And that's something that as we become more mature and more sophisticated in our use of it, I'm sure that's what we're going to do. I'm conscious of time. Stuart, any closing remarks for you on this paper?
No, that's it. Thank you, Chair.
Right, thank you very much. Thank you for a good discussion, and thank you for the deep dive into the BAF risks. Moving on then to, I think it's Amanda. Amanda, if I could ask you to come to the table to talk to us about the CNST. Thank you.
I'm Amanda Rowley. Oh, am I on? Amanda Rowley. I'm Director of Midwifery and Lead Divisional Director for Women's and Children's. I think I can keep the report very brief. You'll be pleased to know, because this is giving assurance of our compliance with Year 6 of the Maternity Incentive Scheme, and the Trust Board and Quality and Safety Committee have been kept briefed throughout this reporting period with a large amount of evidence that's been presented. The evidence I've collated in the appendix, which I appreciate is very large and I won't focus on today, but as there's been quite a few changes in members of the board, I wanted to make sure that the board had the assurance just of the scale of evidence and that it had been presented in various different forums. Oversight has been maintained of this year of the scheme through the division. The quadumvirate leadership have had really good oversight and assurance on every single piece of evidence to meet all the requirements. That's been through divisional governance processes, through Quality and Safety Committee and here today, and has also had scrutiny from the Chief Nurse at the ICB and the members of the LMNS. I'm very proud that we've are able to come today and say that we are fully compliant with all 10 standards of the scheme, which is very great assurance of safety within our service, but it also does come with a sort of financial incentive in that we will get a rebate of 10% of our overall insurance scheme. So very important for the service that we meet these requirements. I wanted to give my thanks because it's been a huge effort with strong accountability of the workstream leads and the members of staff that have been responsible for delivering on the work streams. And within the appendix, you'll just see the huge amount of work that's been undertaken. So I think really, with the evidence accepted, it's for me to ask the boards that you accept the evidence that's been presented around our compliance with Year 6 of the scheme. Have assurance that the evidence has been reviewed and approved by the Quality and Safety Committee and that there's been good oversight from the quadumvirate and that there's been external scrutiny from the ICB, and confirm that you're satisfied that the evidence has been provided to meet the standards, asking that you give permission for our Chief Executive to sign the board declaration form, which will then go to the accountable officer at the ICB and be submitted to NHS resolutions before the deadline.
Thank you, Amanda, and thank you for being so succinct. Any questions or comments from Amanda before we make a decision on that item for approval? David.
Very briefly, we congratulations. Not every trust is going to achieve this. I really think it's fantastic. And just to assure the board that Quality and Safety does look at this on a detailed basis.
Thank you very much.
I was just thinking the timing of whether you were... a general issue, again, echoing congratulations, the detail and the calibre of the information coming through the Quality Committee is exemplary. And I just wondered, with regard to the recent recognition given by regulators and other stakeholders of the improvements, which evidence the robust divisional leadership and the oversight that has been given to date through a combination of the board and the Quality Committee, whether the board wished to consider at any point devolving completely the responsibility to look at continue the level of rigour which we need to maintain for all aspects of maternity service provision, but to the Quality Committee, maybe not for now, but at which point, because it seems like an appropriate juncture to consider that.
A very interesting comment.
And I think a couple of points from me on this. I think this is very heavy to come to the board, but for exactly the reason you described, Amanda, I think it's entirely appropriate this year. I think last year we were very self-critical, and in declaring non-compliance with a couple of standards, there will be other organisations that I expect on self-assessment would declare compliance, and we took that view to be particularly challenging, and we had lots of external scrutiny and concerns about maternity. I think, as Jill says, with the exit from the safety programme, with the re-rating by the Care Quality Commission, and with really robust evidence, A, I'm very happy to sign this, and B, that conversation about when you consider how many patients come through our service and the percentage of women coming through maternity, we've put a lot of board time and papers and whatever, and there is a real risk, as we've discussed, of wood for the trees in this. So I think it's a live conversation in that how do we bed this in, not least because of the confidence we've got in the quality of what's come through the divisional governance structure. So I would very much support that point from Jill.
Yep, Amanda.
Just to say, so year 4 of the scheme, we declared non-compliance just around the time of our CQC inadequate rating, but we were compliant in year 5. And I think that's absolutely right time to have this conversation. I think in terms of NHS resolution, they will always require that there is that oversight from the Trust Board, and I think that a large amount of evidence does now come through Quality and Safety Committee, and within the requirements of the scheme, it's clear that there is more devolvement now, and that they're recognising the role of sub-boards to be able to have those detailed discussions around the detail.
Okay, thank you. Justin, I do want to draw this to an end quickly, but Justin, and then David.
I guess I want to put a slightly different view. And the reason why I want to do that is because I think there will always be a tension between how maternity services are funded and the risks that are implicit within maternity services in the Trust. And we know that we've not come from a good place. And I just wonder about the power of letting those tensions play out at board and therefore I wonder whether this needs to continue having this level of scrutiny.
May be true, but I think what we've had up to now is a level of duplication that we don't need. So that's the key thing to avoid, and absorbing executive function capacities.
I want to call this to an end. I have to say, Adam and I discussed this only last week, and I think our view was very much that along the lines of what Jill and David were saying, that perhaps, you know, the maturity and the sophistication of the reporting we're now getting, that we're not certain that it necessarily needs to be at board, and therefore I think we would probably feel comfortable devolving that, or I should say delegating that to QSC, but also recognising Justin's point. So I think let's have that conversation offline. But I think it is, if that is to happen, it is absolutely credit to the work that has been done by Maternity and the level and, as I say, the maturity and the sophistication of what we're seeing. And I just want to, before I finish this item, so first of all, can I just ask formally, are we comfortable with authorising Adam to sign? Excellent. Thank you very much. And I want to say, please, very much our congratulations. It is not an easy thing to get all 10. It's not an easy thing to do it 2 years running. And as I say, I think it absolutely is testimony to all the hard work that's going on. So thank you very much. But in terms of that wider discussion, please let's take that one offline, because I think that there is an argument for saying you're now big enough and strong enough that perhaps you don't need quite the same level of board level scrutiny, perhaps. But let's have that conversation. Thank you. Right, moving on then very quickly. Yes, Martin, system report. Do you want to say anything?
It's interesting, but it's very dangerous. Contextual value for us.
Great, thank you. I think I'm going to blacklist you. So no, not at all. Not at all.
I can't read things and not have a comment. I'm sorry. No, it's just a brief one. I mean, yes, it is interesting to have these benchmarked issues put in front of us. I wondered if there's a comment in there about the impact of the MAID event, reducing bed occupancy down to 80%, which we all know is, the golden grail. And I just wondered if we could ask the ICB to do some further analysis on comparing bed occupancy across the piece. It's extremely difficult to do that, and certainly of limited value for us to do on our own. And I think that would be something useful to ask the ICB. If it isn't already done.
Bed occupancy. But I think your point is well made, because it's behind the data, because we know, for example, in the context of renal, that's a bit of a theme of the meeting, we are very different to many because of the amount of renal inpatient activity we do. And so some of those percentages are changed. But let's go maybe through the FPC, what that question is, and I'm sure we can pull together something, as you say, led by others, but us bringing it back.
Great, thank you very much for that. If we have no other questions on the system report, if we could move on to committees. I'm conscious of the time, so if we could literally run through this. Audit and risk. Karen, anything you'd like to draw to our attention?
Yeah, just to keep it really quick, 2 updates. So first of all, the Audit and Risk Committee just before Christmas reviews the charity annual report and accounts and approves them on behalf of the board. An unqualified audit opinion was issued then on those accounts, and there isn't any other issues I need to bring to the attention of the board. And the other item is we had a meeting of the Audit Committee yesterday, and we were reviewing the standing orders, SFIs and scheme of delegation, and we do that prior to approval by the board. there were a number of amendments included within that, including things like relating to our teaching hospital status. But what we became aware of was that there are some considerable number of changes that needed to be made to those because of the Procurement Act that's about to become in. So to cut a long story short, it's a breach of standing orders for the board not to receive those documents and approve them on an annual basis. But what we thought at Audit Committee as a proposal was that we made all of the amendments that are currently there available to all members of the board so that you have access to them, but we do not bring the completed documents for you all to read until all of those amendments have been made. They are long documents, and we think it would be a better use of time for board members to read them once when they are complete. So it's likely to be early in the new financial year that is going to happen. So if board members are happy with that approach, then that is what we propose.
Sounds very sensible to me. Comments from the table? Are we comfortable getting them as a job lot once we've got everything? That would sound a lot more sensible. I don't see any dissent, so please let's take that as approved. Thank you, Karen. Finance, performance and planning. Anything to add? Obviously the papers are in there, so we take them as read.
Nothing to add. I think all has been addressed in the discussions.
Thank you very much. Quality and safety. Anything to add?
No, nothing to add.
Thank you. People and culture. There was,
I'm sorry.
I looked down for a second. That's all it took.
No, I will be very quick. I just wanted to make a comment as the nominated board's health and wellbeing guardian, actually, and attending my first meeting of the Quality and Safety Committee, where we received an excellent annual safeguarding report, which gave significant assurance, actually, as the chair has indicated for the committee to receive. But what was very notable for me within that report was the considerable importance that had been given within this extremely stressful aspect of staff work to safeguard vulnerable patients and clients that require resilience and support to maintain their well-being, that the importance was being given to that. And that was very evident within the annual report, and extremely reassuring, and that the importance was being given to that. So I wanted that noted here because it was extremely impressive.
Very much, Jill. That I will accept. Lovely. Thank you very much. Moving on to people and culture, because there was a slight misunderstanding. We don't have a paper in the pack, but Janet, have you got anything you want to draw to our attention?
Just a couple of things. One was just to make people aware, if you're not already, that the Sexual Safety in the Workplace Act has come into place from October 24, and I think we're waiting to hear from NHS England what the likely requirements are around mandatory training, but given all the other demands of mandatory training, I think just putting that on people's radar. And then the other thing was a point of escalation, which arose from the discussions about freedom to speak guardians, and a request for consideration of those freedom to speak up guardians having protected time, which I appreciate in the current sort of financial circumstances is a challenge, but it was something that was requested.
Yeah, and one that we've heard before.
Yeah.
Thank you. What is our it's been escalated to board. How do we want to take that? How do we want to deal with that query? Stuart, I'm looking at you, Stuart, but anyone?
Probably one for Tom.
Is it one for Tom?
Because it involves, budgetary, time.
Yeah, yeah.
Needs to go through our internal mechanisms for reviewing budget and
okay,
and
but you
through
will
our
take
business
that
planning.
one.
I will do. Yeah.
Okay, thank you. If we can have that logged on the action log, though, please, that would be brilliant. Thank you very much. Charity trustee, anything to add, David?
Well, I was hoping that we might give an update on the special charity appeal, which is the Sunshine Appeal, which has been delayed recently due to the new regulations that came out in the spring. I thought we could have a positive update, but Kevin, I think we're stalled, aren't we?
I'm so sorry. Sorry, we've received an update recently, and I haven't had a chance to give it to David about additional costs that are required, believe it or not, just for design changes because of the way in which the planning has now gone with high-rise buildings. So for the board, and I'll be very brief, the planning now goes through the Health and Safety Executive rather than the planning group for high-rise buildings under the Grenfell plan, which means that there are another set of hierarchy reviews to be undertaken by design guidance personnel, which also means we can't talk to the Health and Safety Executive until such time as we've employed a professional lead on that. The figures have come through. I've written to Eloise last night saying what the costs are. Sorry, David, I didn't include you. I meant to catch you this morning. But there's an additional £25,000–30,000 worth of fees on this project before we can even get it onto the Health and Safety Executive. So that's the thing. The reason it's taken quite so long is because there aren't the people out there, to be quite honest. And it's quite confused as to who's actually giving the final approval at the NHS, at the Health and Safety Executive level.
Thank you for that, Kevin.
I just think we should just note the importance, because this was a fantastic appeal. There has been a real drive to get this done because we see the benefit, and it has been really frustrated through the estates market and price inflation after we started it, and most recently this. I'm assured, and I spoke to Eloise yesterday, there is still a real drive working with estates to get this done. But we know that people have been very generous, and some of those people will want to donate to future schemes, but until this one's done. So it's important we do drive it and consider it as a priority in our estates programme.
Absolutely, absolutely. And I think for everyone, I don't know if we actually said it, this was about the open space for the intensive care patients, the balcony, or that it was about making that fit for purpose to allow patients to get some fresh air and access to the outside. So it's a really important project and one that we absolutely support. So we need to try and make this happen, but recognising the additional challenges that Kevin has mentioned. But thank you for that, and thanks, Adam. Right, that concludes the committee reports. In terms of other items, we've got the annual cycle in the papers, which is for noting only. Any other business? There's only one thing, and that was my bad, as it were, at the beginning. I forgot to welcome Jill Hooper to our board as a new non-executive director. Apologies, we got stuck in, and I forgot to say it. So welcome, Jill, and thank you for your contributions during the meeting today. You've hit the floor running, obviously, which is great to see. Our next meeting is on the 12th of March, and that one will be held via Teams. In terms of reflections, we'll take that one after the break. So I'd like to thank everyone for their attention and for joining us today, and I'll draw this meeting to a close. Thank you very much.